Assalamu alaikum wa rahmatullahi wa barakatuh. I am so pleased and happy to present this lecture in such prestigious conference like the Africa Health ExCon. The title is Incretin-based therapy in metabolic associated steatotic liver disease or MASLD patients, which is the hype now in medicine. This is my disclosure. There are no funding for such talk. My introduction. Globally, there is one every three adults has having a MASLD. Among those with type 2 diabetes, the prevalence exceeds even 70%. Up to 20% of them are having advanced fibrosis. And yet, until recently, there was no pharmacotherapy approved. Over the last decade, accumulating data supported the incretin-based drugs for muscle and MASH therapy. First, we begin with the GLP-1 receptor agonist in 2016. Randomized controlled trials showed that exenatide reduced hepatic triglyceride content as measured by proton magnetic resonance spectroscopy by almost 24% versus 12% only. So, at that cascade of studies involving liraglutide subsequent to this original study at 2016, as we can see here, demonstrated the efficacy of liraglutide in achieving muscle resolution either directly or indirectly. Then, by year 2021, a meta-analysis of randomized controlled trials involving almost 940 participants, averagely 70% of them having type 2 diabetes, evaluated GLP-1 receptor agonist, liraglutide, exenatide, and dulaglutide, as well as the semaglutide. Over 26 years, treatment significantly reduced liver fat and improved the liver enzymes in muscle MASH patients, regardless of their diabetic status. So, by the year 2024, research concentrated on the semaglutide for the treatment of MASH and published under the title of Essence Trial. This multi-center randomized double-blind placebo-controlled study enrolled almost 1,200 patients with biopsy-confirmed MASH with fibrosis stages between F2 and F3, who were randomized in 2-to-1 ratio to once weekly sub-Q semaglutide of 2.4 milligram dosage versus the placebo. Of course, this Essence trial was very famous. The results, the interim analysis at week 72 for the first 800 participants showed that once weekly semaglutide 2.4 milligram led to meaningful histological improvement in patients with MASH. Thus, this prompted the FDA to approve this molecule by August 2025 in treatment of MASH with moderate to advanced liver fibrosis, as we mentioned, stage F2 to F3. Well, as regards the dual GLP-1 glucagon agonist, Survodutide significantly reduced body weight, glycated hemoglobin, and hepatic fibrosis, demonstrated by the non-invasive biomarkers as well as biopsy findings in patients with obesity and type 2 diabetes. So, another molecule, which is the Survodutide, in phase 2B trial on patients about 293 with fibrosis between 1 to 3 stage, improved weight, triglycerides, glycated hemoglobin, hepatic fat, and fibrosis without worsening of MASH. Then comes to the dual GLP-1 GIP receptor agonist and the very famous tirzepatide. And here there was two very famous trials, Surpass-3, which used the MRI PDFF, showing almost 15.5% hepatic fat resolution versus insulin deglutide, and the Synergy-NASH trial that showed MASH resolution of 45%, 56%, 62% with dosages of tirzepatide 5, 10, and 15 milligrams versus only 10% with placebo driven by HOME-IR and adiponectin. Then the triple GLP-1, GIP, glucagon, retatrutide in phase 2A randomized controlled trial on almost 100 patients with obesity and muscle. At week 24, there was normalization, which means that the fat content became less than 5% in 27, 52, 79, and 86% when we reached the dose of 12 milligrams versus, of course, 0% with placebo. So what is in the pipeline, or what is the next gen incretins? We have the Survodutide, GLP-1 glucagon dual agonist in phase 3 MASH, Bigdutide, which is also a GLP-1 glucagon in phase 2B, and they claim that it reduces 72% of liver fat. Oral semaglutide, we heard about it, the 25 milligram, but now they are speaking about the 50 milligram in phase 3 for MASH. Then the Vitudide, which is also a GLP-1 glucagon receptor agonist in phase 2, reducing fat with 68% only after 12 weeks. And some small molecule GLP-1 agonists like the danuglipron, which mean that there no injection will be needed. So my take-home message is very simple. MASLD, when confirmed by like FIB4 and the elastography, if stage 0 to 1 plus obesity or type 2, then lifestyle, control the diabetes, and maybe use semaglutide or tirzepatide. In stage 2 to 3, consider high-dose incretins, and of course, the promising retatrutide if available, plus, of course, trial enrollment of the new pipeline molecules. If 4, then we can use GLP-1 receptor agonist for metabolic benefits, but beware, of course, of the hepatic compensation, decompensation. My take-home message is simply saying that incretins are not just anti-diabetic drugs, they are anti-steatotic as well as anti-inflammatory. And thank you very much.